Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And this month for News You Can Use, I am joined once again by Dr. Craig Joseph. He is the Chief Medical Officer at Avaap. Craig, thanks for joining me.
A pleasure as always.
So it's the holiday edition. Everybody's, I guess, wrapping up a little bit. Things are winding down, but there's still plenty going on. And I think, from my perspective, the first thing to talk about is the recent trending topic that was posted by one of the Vox reporters, I think Ezra Klein, who basically said that healthcare costs is a total sham. It's all because of the physicians, because their salaries are too high. That created something of a storm. He got a lot of responses, a lot from physicians, I can tell you, a lot from clinicians in general. There was a little bit of weighing in on both sides. What are your thoughts? Are you paid too much?
Yeah, he's 100% right, Nick. I am paid too much, and I bring very little value to society. And let's just get on to the next topic. Just this a black and white issue, Nick. And all right, that's probably not accurate.
You realize somebody's going to take that as a soundbite and use it, of course.
That's fine. That's fine. It should be the worst thing I've ever said.
Right.
Probably today or written, actually. So of course, I think that it's oversimplified under any circumstances to blame any one party. And I'm at the point now where I say healthcare system. I use the word system in air quotes, right? It's not really a system. A system implies that it's planned out and it works according to some rules. And I'm not convinced that it does in the United States. So. I think you have to look at the totality of the question and context. Comparing what physicians in the United States make to physicians in other countries is not really typically comparing apples to apples. And the reason
are you saying that they're different physicians and they're not as well qualified?
Again, I could just go, yes, absolutely. In Europe, they're horrible doctors, but that's probably not true, and I don't think anyone would even buy that part. No, but I think certainly in the vast majority of other countries, students do not enter medical school and then graduate with hundreds of thousands of dollars in debt. And,
absolutely true.
Right, and so. I'm no expert like Ezra Klein is. I'm not saying that I am, and I'm not sure that he is either. But
I don't know. But wait a second, you're a doctor, aren't you?
I am.
Oh, well, look at that. Wait, so you've actually got some experience in this?
I do. I do have some experience in the United. Yeah, I mean, I went to a. I am just astounded at looking at what the average medical student now graduates and enters residency in terms of debt for the average student. And again, hundreds of you read about 150, 200, $250,000 in medical school debt. I'm not talking about undergrad,
right,
which might even be more. It's just an astounding amount of money. And then it's not like I think many listeners may not realize you don't just walk out of medical school and start making money. You walk out of medical school and then start at least a 3-year residency where you're really considered a trainee, a student, if you would.
And you paid a pittance accordingly.
You are, at least you are paid though, right? So
that's true.
As opposed to medical school where you're
money.
Right, you are earning some money. Certainly, it's a a very small amount compared to what a physician who's graduated from residency and fully licensed would make. But how do you think about that? Graduating from school and you've got a house payment. You have a house that you have paid for, but don't have the house. And so how do you pay back that money with interest over 10 or 20 years? It's significant. And I'm not saying it's a good system. I don't really think it is a good system. However, comparing salaries of physicians in the U.S. to other countries where their entire medical education was subsidized, it's free. They're students. They're not paying for that. Their ability to kind of make do and make a good living with a smaller amount of money, it makes sense, at least for that catch-up period. But again, if you're walking out of school with $250,000 in debt, that's not something that you're going to pay back in 5 years unless you're in a really, really well-paying specialty. And that's another thing I'd love to kind of get into, which is the difference between how much a primary care doctor makes versus how much a super subspecialty surgeon makes on average in the U.S. And that's very different as well. So you can imagine someone who's making, I don't know, $500,000, $800,000 a year is in a much better position to pay back those kinds of exorbitant loans than a physician who's doing internal medicine or pediatrics or family practice, where the pay can be half of that, easily half of that.
So I've got to get on my hobby horse, because I can tell you that I've got personal experience of all of this, and it's not often my hackles go up, if that's a British term. I'm sorry, but it's, the hair on the back of my neck went up when I read this. It just really grated on me. I trained in the United Kingdom under the NHS system. That training in the circumstance that I was in cost me precisely zero. In fact, my local government, county, whatever you want to call it, gave me a stipend that covered my accommodation, my food for the full period of 5 years. In fact, it got bigger when I went into the full time and had no breaks. I came out with zero debt. Now, not all of my colleagues were quite as lucky, but the system was designed to try and at least make it equitable. Now, it's changed slightly, and I will tell you that the British system charges, and I think it's up to a maximum of £12,000. I used to be able to tell you what that was in dollars. These days, I can't even track the changes in the exchange rate. Who knows? It might be up, but it's somewhere in that order of 15,000 or so a year, which, it's not a small amount of money, but it's not a massive amount of money. Compare that to my daughter, who is in second year medical school, and she is enduring precisely what you describe. And I listen to her on a regular basis. I mean, I will tell you, it is the single biggest worry that she has, far beyond the worry of study, which I can tell you is just an overwhelming proposition in terms of the amount of activity, that she's concerned about this just overwhelming weight around her shoulders. And exactly as you described, this whole process of what specialty, and, we desperately need these generalists and people that, have the time and compassion, and people are forced out of that pathway because the financials don't work. You end up on this really low, comparatively speaking, salary. And by the way, you've lost income for the period of time that you were training, which is 4. That's the first degree. Then typically most people are spending a year in between because of the demands for getting into medical school in terms of clinical hours and experience. Some people are able to do it, but it's a pretty tough hill. So that's 5 years, another 4 in medical school. We're talking 9. And I think the minimum is 3 years for a general practitioner.
Yep.
Wait, we're at 12. Is that 30? It's 12 years of non-earning. You can call the residency some earning potential. And yes, you could maybe pay back some of that. But my goodness, that's just such an overwhelming burden. And that drives much of this. It's not the only thing. And that's the thing. If I was to pull out one piece out of this, it's these, individuals, groups, whoever, that say this is the problem in healthcare. There is no single problem, and there is no single solution. And yeah, we could say, right, wipe out all medical student debt and, make it free. That wouldn't solve the problem, to be clear. But to sort of apportion blame in that way, and particularly at the clinicians who all enter, I think the vast majority, with absolutely the humblest and most compelling of reasons to get into medical school, and then go, yeah, but it's all your fault. You're too rich and you're paid too much, is just really galling to me, quite frankly.
Yeah, and the system, the The system is, one might say it's upside down. It, really rewards people who do procedures. We call them generally surgeons, but all kinds of specialists do procedures, and
Right.
that's what pays quite well. And in primary care, again, when I'm talking about primary care in the U.S., I'm talking about family practice, which is similar to what I think you call general practice, and then pediatricians and internal medicine doctors. And generally the charges that we drop are called evaluation and management, E&M.
Right.
Evaluation and management codes. That's how we bill insurance companies. And so, we're paid to think. Not saying that surgeons and proceduralists don't. Obviously, they do, but we're really paid to talk to the patient and to kind of create a plan and come up with the proper course that the patient should take. And we don't end up with we've not healed a bone, we've not sutured a wound. You can't really see what we've done, and the way we pay for physician services in the United States is kind of backwards. I always give this one story. Again, as a primary care pediatrician, I spent my day mostly in the office seeing kids up to babies, newborns up to adolescents. I would get paid. Occasionally, someone would come in with a toddler would come in with what we call a nursemaid's elbow. And that's what you get when you grab a small child by their arm and pull them up. They're having a tantrum typically, and you pull them up from not meaning to hurt them in any way, and all of a sudden they start screaming and they can't move their arm. Their arm sits at their side. It's pretty classic, and They rush them in to the pediatrician into my office, and I look at them and they look in a pretty classic way, and I you get the story, and like, yeah, well, he was crying or he was on the ground, and I kind of picked him up with this one arm, and like, okay, that's nursemaid's elbow typically. Yeah, I'll look around. I can fix that in the office, and if I think it's a nursemaid's elbow, I don't need an X-ray because X-rays generally don't even tell me if it is.
Right.
And I essentially just manipulate the arm in such a way. It takes about half a second, and the elbow kind of pops right back in. Sounds horrible. Kid cries. About 5 seconds later, he's fine. And it's almost like a miracle worker, right?
Yeah.
And this would happen very uncommonly in my office, a couple times a year maybe. I got paid for fixing that. Fixing, I say again in quotations, because it, took me about 2 minutes of listening and 30 seconds of doing. I got paid the same as I would maybe for seeing 3 or 4 kids with ear infections. 3 or 4 kids with ear infections, which again, that's not hard, but neither was fixing that subluxation of the radial head, the nursemaid's elbow. That's how upside down, how perverted our payment system is. I did something. I had what they call a CPT code. I had a code that I could submit, and the insurance company would gladly pay me all this money, which I'm here to say, like, I didn't really deserve. I don't really feel like I deserve that much money for doing that procedure in the office, but it was a procedure, and in the U.S. I got paid a lot of money for it. So of course I did submit it, and I gladly took that money. But boy, I would like to have gotten paid a little less for that and a little more for the ear infection kids, because then kind of that evened it out. And that's why primary care docs are at the bottom of the pay scale. Again, physicians make more money than almost everyone on average, and I'm not saying that's not the case. But just like you said, there is no golden problem in the U.S. healthcare system. That it's not the physician's salary, it's not just that, it's everything from the beginning of medical education to how we decide how quality is performed, who are good doctors and who are not so good doctors, and what are good healthcare systems and hospitals and not so good healthcare systems and hospitals, and how do you determine that? Oftentimes you ask the patient, and I've often said, you're asking the patient if they've gotten good quality care, and typically they make that decision about how much they like the doctor or the nurse. And you can have a completely incompetent doctor. You can have a completely incompetent doctor, but he's got a great bedside manner, and he'll get great scores on quality from the patients. But he's in the way we really should be checking quality, he would be at the bottom.
So, the one point I would take issue with that you said was you're paid to think. I would say you're not paid to think. That's part of the problem. That's the sort of one of the foundational principles in all of this. And one of the things that my overriding sort of principle in all of this was that I don't want to live to work. I want to work to live. And the system didn't sort of enable that from my perspective. And the final thing I would say is that the piece by Atul Gawande talked about this in sort of fairly extensive detail. It was really about incremental improvements, and it was around the 2-year journey of a headache for one patient with their family practitioner, general practitioner. That was never one single thing. It was all of these moving on because of the complexities of the human body. It's just none of this is simple, and that's I think my overriding issue is just simplifying it and trying to nail people for specific things just doesn't help. But
it's Twitter.
Yes, that's instant gratification. But it does, so we were set to sort of talk about something else, which was this whole free medical tuition, which Geisinger is offering. The new Kaiser Medical School is saying, hey, we're going to give free medical tuition. And, I applaud them for the sort of concept, but it does sort of still create this discrepancy, because unless you do it for all these people, suddenly there's all these folks that have this, wow. And I can only imagine the competition to get into those places to have a free leg up. If I gave you a $250,000 bonus check for 4 years of work, that would be pretty significant. But applaud them for that. Any thoughts about offering free medical tuition? Do you think there's a path to that? Is that a possibility, or at least bringing it down, maybe?
Yeah, I mean, I think it's a great, like you said it, it's a great idea. But now you're talking about 2 or 3 medical schools in the United States out of, I think there's 120 or 130 or some number along that line of medical schools in the U.S. And so certainly number one, and we talk about $250,000. $250,000 of savings for a 22-year-old is completely different than $250,000 worth of savings for a 52-year-old. Just throwing that out there, because they're going to be paying that over so much time, as opposed to someone who's making money. I think it's a great idea, and I don't know how they're going to sustain it when they're competitive. They're competing with other medical schools where they are collecting these kind of crazy $50,000, $60,000, $70,000 tuitions. And so, God bless them. And if they've got the foundation and support and charitable support to do it. But I suspect we will not see medical students graduating from these institutions and saying, well, I was going to do this very high-paying, high-prestige, specialty, but now I'll just go into, primary care because I kind of feel an obligation to do that. And there are absolutely people who want to do those high-paying, high-prestige jobs. That's what they've wanted to do, and they would do it whether they got paid a lot or very little, no question. But there's also people like your daughter who are struggling with this now, and they might have, well, I could do this, or I think I could be happy doing this, or I could be happy doing that. It will be interesting to see what the specialty ranges are, percentages are for what kind of training these folks are going to do, who walk out with $0. And let's be clear,
we have to watch. Have to see the data, and we're at least 7 years out, right? Because if they're just starting,
it's going to be it's going to be a while, but it will be
longer because they're going to go for the other specialties, which are longer training anyway.
Yeah,
because they can afford to, because they don't have the debt from the first 4 years.
Correct, and again, there are absolutely medical students who come from wealthy families who don't have any tuition.
Right.
Who have tuition, but they don't have to pay it. They don't have to worry about that. And I don't know if anyone's ever studied that. That would be interesting to see too. If you could get people to tell us what was your, at the time you graduated from medical school, how much debt did you have, and what did you choose to specialize in? And to see if they did more primary care. The world needs more primary care doctors.
It does.
And that is the least paid specialty kind of doctor in the United States, at least. And I don't believe that's the case in Europe.
No, I don't think so. It's although there is some discrepancies, but it's not quite as pronounced. The difference is
Yeah.
not as large. Extending this just a little bit, there's this whole virtual training thing that we're reading about the last few weeks, and that YouTube is replacing real training. Maybe the day of the medical school is gone in the same way that universities are gone, and we can all do it on, hey, just sit at your screen and learn to be a doctor.
That sounds great. Let's move on to the next topic. I think we've just wasted a lot of time now talking about medical schools when they're all going to close. Certainly virtual training makes complete sense for some things. And especially for procedure-oriented things, right? So how do you do this approach for this surgery that you haven't done in a while, and you want to go and watch someone do it? This one, you're not going to go and watch a 2-hour operation, I don't think, if you're a practicing surgeon. But you might say, I forgot how they removed that flap or how they did that particular part of this procedure, and to kind of fast forward to an expert who's done it and is kind of talking through. Now, if I were as a primary care doc, as a pediatrician, I'm sure I wouldn't be able to go through and look at a heart surgery and go, aha, that technique was amazing.
Right.
Because I don't do surgery. But for those who are in the field and to be able to watch that, I think that makes complete sense, especially for procedures. Now, I don't think most medical schools are at risk of going under because of YouTube. I don't think colleges are probably at risk of going under because of YouTube. But
I will tell you, parents are, because I've been told that by my own children. No, that's all right, Dad. I'll just YouTube it. So maybe the parents are.
Hey, I'm happy to let other people do some of those things. As they say, the more things change, the more they stay the same. I definitely remember when I was in medical school, and that was the very early 90s, there were students who during the first 2 years, I never saw. Like, they never came to class. They
still
read
going on today.
Correct. Well, I think now we have YouTube and we have other ways of getting that information.
They're recording the sessions, and the students, and I'm not going to name any names, but I do have some deep insights. Listen to the lectures at 1.5 to 2x.
Yeah.
Because they can compress, and by the way, they can look at the slides and take notes at the same time in a much more sort of appropriate circumstance than in sitting in an uncomfortable lecture hall.
And there's nothing wrong with that. There wasn't anything wrong with it. Some people learn better that way. Some people learn being in a class and being able to whisper to someone like, I always found that confusing. What do you think about that? And so I'm not sure that it's totally changed everything. I think there are always going to be people that are going to be wanting to go to a class and talk through things, and there are always going to be people who want to sit at their house or sit at the library and just learn on their own. And it's kind of like turning things upside down in the classroom. You're not learning in the classroom anymore. You're now reinforcing or answering questions in the classroom. So it's a big change.
So as usual, unfortunately, we've run out of time. We certainly have more topics to talk about, but that's always the case. It only remains for me to wish all the listeners a very happy holidays. I would encourage you to go listen to my 3 whiskey tasting that I posted as your holiday sampler. One of which, those bottles, is still available if you were interested, so you can get it. And if you're interested in getting those tastings, I'll be running those at HIMSS. Nextgate is actually sponsoring one of those tastings, so an opportunity. And maybe if you wanted to run it for yourself, you could actually sponsor a whiskey tasting. How about you, Craig? Any thoughts for the holidays?
Well, I think my main wish for everyone would be happy and healthy next year, and to survive the holidays with their family by probably not talking about politics or healthcare funding. Those are probably 2 things that you should avoid, and that would be my advice.
Fantastic. Craig, thanks for joining me once again.
Thank you.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com, and tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.